So maybe we can talk a little bit practical management points, highlighting some of the adverse events for each of those JAK2 inhibitors. How do you monitor patients? What are you going to look for? Kind of practical, recommendations for the practicing oncologist. What to look for? What are the adverse events or profile of each of those JAK2 inhibitors?
Sure. So again, at this time, we only have ruxolitinib and fedratinib. For ruxolitinib, it's a very well tolerated drug for the most part. Headaches, dizziness, and bruising are the three top non-hematologic side effects that we see, and they're generally not very bothersome. Now, anemia and thrombocytopenia are real issues. That's from on-target JAK2 inhibition. So again, you can use some alternative dosing, as we talked about earlier, especially now that that is backed up by the REALIZE trial in anemic patients. And you can support the anemia with things like danazol or erythropoietin analogs or something like low-dose thalidomide. All this has been studied. That is something I will often do. And then the anemia does get better. It's at its worst over the first 12 to 24 weeks and then gets better. And also it's been shown that Rux-induced anemia is not prognostically adverse,
Mm.
unlike disease-induced anemia. So that's important to keep in mind. Otherwise, weight gain is something we see. Some patients complain about it. It can be a good thing or a bad thing. And then shingles. So shingles reactivation has been seen more in the PV patients in the ruxolitinib clinical trials, but you can see it in the MF patients. So I vaccinate all of them with the new killed vaccine against shingles. Checking cholesterol once a year is important, as Rux can increase cholesterol as well. Now, with fedratinib, again, anemia and thrombocytopenia, this is on target. There's really not a way around it, I guess, with the inhibiting JAK2, unless you have a different mechanism like momelotinib does. Um, and other than that, however, because fedratinib inhibits FLT3, like pacritinib, you can see a fair amount of nausea, vomiting, and
Yeah.
diarrhea, which is important to be proactive about. Fedratinib development was initially derailed by the whole Wernicke's encephalopathy of fear, which of course, later those cases were analyzed and only one case was found to be a proven case. But still, given that background, it's particularly important to make sure that patients are not getting malnourished. For example, thiamine supplementation is sometimes recommended. Some physicians will do it routinely, others will do it if needed, just to prevent something like that from happening. But I would be careful in a patient that's malnourished or alcoholic, things like that, because they are set up to get something like that. And also the drug can cause this nausea, vomiting, diarrhea, which can make them have reduced oral intake and things like that. But I think those would be the main concerns, proactively managing the GI side effects.
Absolutely. I totally agree with you. I usually will start like checking blood counts maybe weekly or every other week when I start those treatments. I almost kind of educate the patients that, the nadir is going to be around week 8 to 12. Uh, if they are tolerating, I try to escalate to a more meaningful dose for spleen response. But like close monitoring early on is essential. With fedratinib, we do check B1 level upfront.
Hmm.
We sometimes give patients prophylactic antiemetic to avoid the GI toxicity that you mentioned. I think really the key is like the first few months of the treatment, the close monitoring with the blood counts. And once you get to that period or time you mentioned, things settle down that patients can be seen once a month with easier follow-up for those patients.